Good day, esteemed colleagues and future leaders in dermatology. Today, we will delve into a comprehensive exploration of leprosy, also known as Hansen's disease. This lecture is tailored specifically for dermatologists and residents who aspire to deepen their understanding of this complex and historically significant condition. Our focus will be on the medical and clinical aspects, including detailed clinical findings, diagnostic approaches, and evidence-based treatment protocols with specific dosages. Leprosy is a chronic infectious disease caused by Mycobacterium leprae, an acid-fast, rod-shaped bacillus. It primarily affects the skin, peripheral nerves, mucosa of the upper respiratory tract, and eyes. Leprosy is one of the oldest diseases known to humankind and continues to be a significant public health challenge in certain regions of the world. Epidemiology. Global burden. Despite global efforts, leprosy remains endemic in several countries, notably India, Brazil, and Indonesia, according to the World Health Organization, WHO. Over 200,000 new cases are reported annually worldwide. Transmission. Leprosy is thought to be transmitted via respiratory droplets from untreated, infected individuals. Close and prolonged contact is usually required. Incubation period. The incubation period ranges from 6 months to over 20 years, with an average of 5 years. Etiology. Causative agent. Mycobacterium leprae and Mycobacterium lepromatosis are the primary pathogens. M. Leprae has a unique predilection for cooler body temperatures, 27 to 33 degrees Celsius, explaining its affinity for the skin and peripheral nerves. Pathogenesis. Immunological response. Leprosy manifests along a spectrum determined by the host cell-mediated immune (CMI) response. Strong CMI response leads to paucibacillary disease with localized lesions, tuberculoid leprosy. Weak CMI response results in multibacillary disease with widespread lesions, Lepromatous leprosy. Transmission and infection. Mode of transmission. Inhalation of infectious droplets. Skin-to-skin contact, less common. Possible zoonotic transmission from armadillos, in certain regions. Pathogen entry and spread, entry through nasal mucosa or broken skin. Hematogenous spread to peripheral nerves and skin. Nerve involvement, Schwann cells. M. Leprae infects Schwann cells, leading to nerve damage. Nerve damage mechanisms. Direct bacterial invasion, immune-mediated inflammation. Clinical features. Leprosy presents a wide range of clinical manifestations, which are essential for diagnosis and classification. Classification systems. Ridley-Joplin classification, based on clinical, histopathological, immunological, and bacteriological criteria. Types: tuberculoid, TT, borderline tuberculoid, BT, borderline, BB borderline. Lepromatous, BL, Lepromatous, LL, indeterminate, WHO classification, simplified for treatment purposes. Paucibacillary, PB, 1 to 5 skin lesions, negative slit skin smears. Multibacillary, MB, more than 5 skin lesions, positive slit skin smears, skin lesions, hypopigmented or reddish patches, often with loss of sensation. Erythematous papules and nodules, especially in Lepromatous leprosy. Plaques, well-defined or ill-defined margins. Diffuse infiltration, leading to thickened skin. Leonine facies in LL. Nerve involvement, peripheral nerve enlargement, palpable nerves, e.g., ulnar. Posterior auricular. Sensory loss, stocking glove distribution. Loss of temperature and light touch sensations. Motor weakness, muscle wasting, claw hand, foot drop. Other clinical signs: eye involvement, logophthalmus, corneal ulcers, nasal mucosa involvement, nosebleeds, nasal congestion. Systemic symptoms, rare, but may include fever during reactions. Leprosy reactions, type 1 reaction, reversal reaction, occurs in borderline leprosy. Features: acute inflammation of existing lesions, nerve tenderness and pain, edema, Cause: sudden change in CMI response. Type 2 reaction: Erythema nodosum leprosum occurs in Lepromatous and borderline Lepromatous leprosy. Features: painful nodules, fever, malaise, joint pain, orchitis, nephritis, systemic involvement. Cause: immune complex mediated reaction. Diagnosis: accurate diagnosis is crucial for effective management and prevention of transmission. Clinical evaluation: detailed history, symptom onset and progression, contact with known leprosy patients, travel to endemic areas, physical examination, thorough skin and neurological examination, assess for hypopigmented patches with sensory loss, palpate peripheral nerves for enlargement and tenderness. Laboratory investigations: skin smear, slit skin smear, procedure, incision and scraping of dermal tissue, staining with Ziehl-Neelsen method. Findings: detection of acid fast. Bacilli, AFB. Bacterial index, BI, grading from 0 to 6. Skin biopsy, histopathology, tuberculoid leprosy, granulomatous inflammation with Langerhans giant cells, few or no bacilli, Lepromatous leprosy. Foamy macrophages, Faraco cells, filled with bacilli, Grant's zone beneath the epidermis. Staining, Fite-Faraco stain for better visualization of M. lepri. Nerve biopsy, considered when skin lesions are absent, but neuropathy suggests leprosy. Serological tests, limited utility. Phenolic glycolipid PGLI, antibody test, may aid in diagnosis of multibacillary cases. Molecular diagnostics, polymerase chain reaction, PCR, high sensitivity, useful in difficult cases. Additional assessments, sensory testing, monofilament testing for light touch, temperature and pain sensation, motor function testing, muscle strength assessment, eye examination, slit lamp examination to detect ocular involvement. Treatment protocol: the cornerstone of leprosy management is multidrug therapy, MDT, as recommended by the WHO. MDT is highly effective, reduces the risk of drug resistance, and interrupts transmission. General principles: early diagnosis and treatment, prevents disability and transmission. Compliance with therapy, ensures effectiveness and reduces relapse. Monitoring and management of reactions, essential to prevent nerve damage. WHO recommended MDT regimens. Paucibacillary leprosy, PB, definition: 1 to 5 skin lesions, negative skin smears, duration: 6 months. Medications and dosages: rifampicin, dose 600 mg once monthly, supervised. Administration: oral. Dapsone, dose 100 mg daily, self-administered. Administration: oral. Regimen summary: supervised monthly dose. Rifampicin 600 mg, dapsone 100 mg, daily self-administered dose. Dapsone 100 mg. Multibacillary leprosy, MB, definition: more than 5 skin lesions. Positive skin smears. Duration: 12 months. WHO, but some national programs recommend 24 months. Medications and dosages: rifampicin, dose 600 mg once monthly, supervised. Administration: oral. Clofazimine, dose 300 mg once monthly, supervised, and 50 mg daily, self-administered. Administration: oral. Dapsone, dose 100 mg daily, self-administered. Administration: oral. Regimen summary: supervised monthly dose, rifampicin 600 mg, clofazimine 300 mg, dapsone 100 mg. Daily self-administered dose, clofazimine 50 mg, dapsone 100 mg. Alternative regimens: for rifampicin-resistant cases, consult WHO guidelines or specialized centers. Possible use of second-line drugs like ofloxacin, minocycline, or clarithromycin. Treatment of leprosy reactions: type 1 reaction, Reversal reaction, management, corticosteroids, prednisone/prednisolone, initial dose, 40 to 60 mg/day. Tapering, gradually reduce over several weeks to months, depending on response. Continue MDT. Do not stop anti-leprosy medications. Type 2 reaction, erythema nodosum leprosum ENL, management, thalidomide. Dose, 100 to 300 mg/day. Notes, highly effective. Contraindicated in pregnancy due to teratogenicity. Strict contraceptive measures. Required for women of childbearing age. Corticosteroids, prednisone/prednisolone, dose, 40 to 60 mg/day. Use, if thalidomide is contraindicated or unavailable. Clofazimine, dose, up to 300 mg per day in divided doses. Notes, has anti-inflammatory properties. May cause skin discoloration. Analgesics and antipyretics, for symptomatic relief. Management of neuritis, prompt treatment, to prevent permanent nerve damage. Corticosteroids, prednisone/prednisolone, dose, 1 to 1.5 mg/kg/day. Duration, gradually tapered over several months. Monitoring and follow-up, regular assessments. Monthly during MDT. Monitor for drug side effects, adherence, and signs of reactions. Nerve function assessment early. Detection of deterioration. Post-treatment surveillance. Annual checkups for at least 5 years in PB and 10 years in MB cases. Side effects and management. Dapsone, common side effects, hemolysis, especially in G6PD deficiency, methemoglobinemia. Monitoring, regular hemoglobin levels. Rifampicin, common side effects, hepatotoxicity, gastrointestinal disturbances. Notes, causes red-orange discoloration of bodily fluids. Clofazimine, common side effects, skin pigmentation. Red-brown discoloration, gastrointestinal disturbances. Notes, pigmentation reversible but may affect compliance. Thalidomide side effects, teratogenicity. Peripheral neuropathy. Monitoring, regular neurological assessments. Preventing disability, rehabilitation, physiotherapy, to maintain muscle strength and joint mobility. Occupational therapy, adaptations for daily living activities. Protective measures, skin care, educate patients on inspecting limbs for injuries. Footwear, custom shoes to prevent ulcers. Patient education and counseling, disease understanding, explain the nature of leprosy and its treatability. Compliance importance, stress adherence to MDT to prevent resistance and relapse. Stigma reduction. Encourage social support and reintegration. Family screening, close contacts should be examined. Building upon our comprehensive understanding of leprosy's clinical aspects, we will now delve into realistic clinical case studies. These cases are designed to illustrate the diverse presentations of leprosy, highlight diagnostic challenges, and discuss appropriate management strategies, including treatment protocols with specific dosages. Through these case studies, we aim to enhance your clinical acumen and prepare you to confidently diagnose and manage leprosy in your practice. Case Study 1: Tuberculoid leprosy in a young adult. Patient profile: name Mr. A, age 25 years old, gender male, occupation agricultural. Worker residence: rural area in an endemic region, chief complaint: hypopigmented patch on the left forearm with numbness for 6 months. History of present illness: the patient noticed a light-colored patch on his left forearm approximately 6 months ago. The patch has slowly increased in size. He reports a loss of sensation over the affected area, leading to minor burns and injuries without noticing. No pain or itching associated with the lesion. No systemic symptoms such as fever or weight loss. Past medical history: no significant medical history. Known allergies. Family and social history: lives with his family in a small village. No known family history of leprosy. Close contact with neighbors who had similar skin lesions, details unknown. Physical examination: general examination, vital signs within normal limits. No lymphadenopathy. Dermatological examination, skin lesion, a single, well-defined, hypopigmented macule measuring 8 cm x 6 cm on the extensor surface of the left forearm. The surface is dry and hairless. Borders are sharply demarcated. Sensory testing. Loss of touch and temperature sensations over the lesion. Pain sensations slightly reduced. Neurological examination, peripheral nerves, thickening of the left ulnar nerve at the elbow. Nerve is non-tender. Motor function, normal muscle strength in the upper limbs. No muscle wasting observed. Other systems, unremarkable. Differential diagnosis, tuberculoid leprosy, post-inflammatory hypopigmentation, vitiligo, tinea versicolor, morphea, localized scleroderma. Investigations, slit skin smear, sites sampled, lesion edge and earlobes. Result, negative for acid-fast bacilli. AFB. Skin biopsy, histopathology findings, presence of well-formed granulomas composed of epithelial cells and Langerhans giant cells in the dermis. Grant's zone present beneath the epidermis. Nerve twigs within the granulomas. No AFB detected with Fite-Faraco stain. Complete blood count, CBC, within normal limits. Liver and renal function tests, normal. Diagnosis, tuberculoid leprosy, TT, based on clinical presentation, negative skin smear, and histopathological findings. Management, treatment regimen, paucibacillary multidrug therapy, PBMDT. For 6 months. Rifampicin dose, 600 mg once monthly, supervised. Administration, oral. Dapsone dose, 100 mg daily self. Administered. Administration, oral. Patient education, explanation of the disease, its transmission, and the importance of adherence to treatment. Reassurance regarding the effectiveness of therapy. Advice on avoiding self-injury due to sensory loss. Encouragement to inform close contacts to seek medical evaluation. Follow-up plan, monthly visits to monitor compliance, drug tolerance, and any signs of reactions. Sensory and motor nerve function assessment at each visit. Outcome, at 6 months, lesion shows signs of repigmentation and reduction in size. No new lesions developed. Sensation partially improved over the lesion. No adverse drug reactions reported. Post-treatment. Surveillance. Annual checkups planned for the next 5 years. Discussion. Key learning points. Clinical recognition. Single hypopigmented anesthetic patch with nerve involvement suggests tuberculoid leprosy. Diagnosis. Negative slit skin smear does not rule out leprosy. Histopathology is crucial. Management. PBMDT is effective, adherence is essential. Follow-up, monitoring for nerve function improvement and early detection of reactions. Case Study 2. Lepromatous leprosy in a middle-aged man. Patient profile. Name Mr. B. Age 45 years old. Gender. Male. Occupation. Tailor. Residence. Urban area with immigration history from an endemic country. Chief complaint. Multiple skin lesions over the body with numbness and weakness in hands and feet for 2 years. History of present illness started with symmetric, diffuse skin lesions on the face and ears, gradually spreading to the trunk and limbs. Lesions are numb, not itchy or painful. Progressive weakness and numbness in both hands and feet. Difficulty in buttoning clothes and holding objects. Episodes of nosebleeds and nasal stuffiness. Past medical history. No significant illnesses. No history of tuberculosis. Family and social history. Married with 2 children. No one else in the family has similar symptoms. Immigrated from an endemic country 5 years ago. Physical examination, general examination, mild facial puffiness. Loss of eyebrows, matarosis. No lymphadenopathy. Dermatological examination, skin lesions, multiple, symmetrical, poorly defined erythematous macules, papules, and nodules over the face, ears, trunk, and limbs. diffuse infiltration of the skin giving a shiny appearance, leonine facies due to skin thickening, hypoesthesia over lesions, neurological examination, peripheral nerves, thickened bilateral ulnar, radial cutaneous, peroneal, and posterior tibial nerves. Nerves are non-tender. Sensory testing, glove and stocking pattern of sensory loss, loss of temperature, pain, and touch sensations. Motor function, weakness of intrinsic hand muscles leading to claw hand deformity, foot drop due to peroneal nerve involvement. Other systems, nasal examination, depressed nasal bridge, saddle nose deformity, nasal septum perforation, ophthalmic examination, bilateral logophthalmus, corneal hypoesthesia, differential diagnosis, Lepromatous leprosy, sarcoidosis, cutaneous lymphoma, post-Kala-Azar dermal leishmaniasis, secondary syphilis, investigations, slit skin smear, sites sampled, earlobes, forehead, elbows, knees. Result positive for AFB with a bacterial index, BI, of 6. Skin biopsy, histopathology findings, epidermal atrophy with a subepidermal clear zone, Grent's zone. Dermis shows sheets of foamy macrophages, Faraco cells, packed with AFB. Fite-Faraco stain positive for numerous bacilli, complete blood count, mild anemia, liver and renal function tests, within normal limits. Nerve conduction studies, evidence of demyelinating polyneuropathy. HIV test, negative. Diagnosis, Lepromatous leprosy, LL, based on clinical features, positive skin smears. And histopathology. Management, treatment regimen, multibacillary multidrug therapy, and BMDT, 4. 12 months, consider extending to 24 months due to severe disease. Rifampicin, dose, 600 mg once monthly, supervised. Clofazimine, dose, 300 mg once monthly, supervised, and 50 mg daily, self-administered. Dapsone, dose, 100 mg daily, self-administered. Management of neuropathy, physiotherapy, to maintain muscle strength and prevent contractures. Protective measures, educate on injury prevention due to sensory loss. Management of deformities, orthotic devices, splints for hands and feet. Referral to reconstructive surgery, considered after disease stabilization. Patient education. Discuss the chronic nature of the disease. Importance of strict adherence to MDT. Potential side effects of medications. Strategies to prevent disability. Psychological support due to disfigurement. Follow-up plan, monthly evaluations during therapy. Monitor for leprosy reactions, especially type 2, ENL. Regular ophthalmic examinations. Outcome, at 6 months, improvement in skin lesions, reduced erythema and infiltration. Neuropathy remains but no progression. Mild skin discoloration due to clofazimine. At 12 months, completion of MDT, BI decreased to 2. Continues physiotherapy, muscle strength slightly improved. Post-treatment surveillance, annual monitoring for at least 10 years. Discussion, key learning points, clinical features, symmetrical skin lesions, diffuse infiltration, nerve involvement indicate Lepromatous leprosy. Diagnosis, high BI and slit skin smear confirms multibacillary disease. Management, and BMDT is essential, may need to extend duration. Complications, monitor for ENL reactions, early intervention reduces morbidity. Disability prevention, multidisciplinary approach involving physiotherapy and rehabilitation. Case Study 3, borderline leprosy with type 1 reaction, patient profile, name, Ms. C, age, 30 years old, gender, female, occupation. School teacher, residence, suburban area, chief complaint, sudden swelling and redness of existing skin lesions with severe pain and nerve tenderness. History of present illness, diagnosed with borderline tuberculoid leprosy 3 months ago. On PBMDT, has been compliant with treatment. Developed acute worsening of skin lesions over the past week. Experiencing severe pain in the right ulnar nerve distribution. No systemic symptoms like fever. Past medical history, no other chronic illnesses. Not pregnant. Physical examination, dermatological examination, multiple hypopigmented plaques with elevated, erythematous borders on arms and legs. Lesions are edematous and tender. Neurological examination, peripheral nerves. Right ulnar nerve is thickened and acutely tender. Motor weakness in the right hand, decreased grip strength. Other systems, unremarkable. Diagnosis: borderline leprosy with type 1, reversal, reaction, management, immediate intervention, corticosteroid therapy, prednisolone, initial dose, 40 mg per day orally. Plan: maintain dose for 2 weeks, then taper gradually over 12 weeks based on clinical response. Continue MDT. Do not stop anti-leprosy medications. Monitoring, regular assessment of nerve function. Watch for side effects of steroids, e.g., hyperglycemia, hypertension. Patient education, importance of reporting any new symptoms promptly. Adherence to both MDT and corticosteroid regimen. Lifestyle modifications to mitigate steroid side effects. Follow-up plan, weekly visits during the initial phase. Adjust steroid dose according to response. Long-term monitoring for nerve function and reaction recurrence. Outcome: after 4 weeks, significant reduction in skin lesion inflammation. Pain and tenderness in the ulnar nerve decreased. Motor function of the right hand improved. Steroid tapering, prednisolone dose reduced gradually without recurrence of symptoms. Completion of MDT, completed PBMDT as scheduled. Discussion: key learning points. Type 1 reaction occurs due to increased cell-mediated immunity, can cause nerve damage. Management: prompt initiation of corticosteroids is crucial to prevent permanent nerve impairment. Continuation of MDT, essential. Reactions are immune phenomena, not drug side effects. Monitoring: regular nerve function assessment is critical during reactions. Case Study 4, Erythema Nodosum Leprosum, ENL, in Lepromatous leprosy. Patient profile: name Mr. D, age 38 years old, gender male, occupation construction worker, residence, endemic area, chief complaint painful nodular eruptions over the body with fever and joint pains. History of present illness. Diagnosed with Lepromatous leprosy 6 months ago. On MBMDT, compliance reported. Developed acute onset of painful, red nodules on arms, legs, and face, accompanied by high-grade fever, malaise, and arthralgia. Swelling of hands and feet. Past medical history: no known drug allergies. No other chronic illnesses. Physical examination, dermatological examination, multiple erythematous, tender nodules ranging from 1 to 5 cm in diameter. Lesions present on the face, arms, legs, and trunk. Some nodules are fluctuant but not ulcerated. General examination, temperature: 39 degrees Celsius 102.2 degrees Fahrenheit, pulse 100 beats per minute, blood pressure 130/80 mmHg, musculoskeletal examination, tenderness and swelling in small joints of hands and feet. Neurological examination, pre-existing peripheral nerve thickening, no new neurological deficits. Diagnosis: type 2 reaction, Erythema Nodosum Leprosum ENL, in Lepromatous leprosy. Management: immediate intervention, thalidomide dose, 200 mg per day orally in divided doses. Notes: strict contraception measures as thalidomide is teratogenic. Obtain informed consent. Analgesics and antipyretics, paracetamol, acetaminophen 500 mg every 6 hours as needed. Continue MDT. Anti-leprosy medication should be maintained. Monitoring: regular assessment for side effects of thalidomide, e.g., peripheral neuropathy. Monitor complete blood counts. Alternative: if thalidomide contraindicated, prednisolone dose 40 to 60 mg/day orally. Tapering, gradual reduction over several months. Patient education, importance of adherence to treatment. Education on contraception and avoidance of pregnancy. Inform about potential side effects and when to seek medical help. Follow-up plan, weekly visits initially. Adjust the thalidomide dose based on response. Long-term monitoring for recurrence of ENL. Outcome: after 2 weeks, significant reduction in nodules and pain. Fever subsided. Joint symptoms improved. Long-term management: thalidomide dose reduced to 100 mg per day. No significant side effects reported. ENL episodes controlled. Discussion: key learning points. ENL management. Thalidomide is highly effective but requires careful patient selection and monitoring. Contraindications: thalidomide is contraindicated in women of childbearing potential unless strict precautions are taken. Alternative therapy: corticosteroids are effective but have long-term side effects. Multidisciplinary approach. Coordination with rheumatology and neurology may be beneficial. Case Study 5: Indeterminate leprosy in a child. Patient profile: name, Mastery, age, 8 years old, gender, male, residence, rural area, chief complaint, single hypopigmented patch on the cheek for 4 months. History of present illness: mother noticed a light-colored patch on the right cheek. The patch has not changed significantly in size. No pain, itching, or scaling. Child reports decreased sensation over the patch. Past medical history: generally healthy. Immunizations up to date. Family and social history: no known family history of leprosy. Attends local school. Physical examination: dermatological examination. Single hypopigmented macule measuring 3 cm in diameter on the right cheek. Borders are ill-defined. Sensation to light touch and temperature is reduced over the lesion. Neurological examination: no nerve thickening detected. Motor function intact. Differential diagnosis: indeterminate leprosy, pityriasis alba, early vitiligo, tinea versicolor. Investigations: slit skin smear, result, negative for AFB, skin biopsy, histopathology findings, mild perivascular and periadnexolymphocytic infiltration, occasional acid-fast bacilli seen with Fite-Faraco stain, Monta test, tuberculin skin test, positive, 15 mm in duration, diagnosis. Indeterminate leprosy. Management, treatment regimen. Pulsabacillary MDT for 6 months. Rifampicin, dose, 450 mg once monthly, supervised. Note, adjusted dose for children under 35 kg. Dapsone, dose, 50 mg daily, self-administered. Patient and family education, explanation about the disease being treatable. Importance of medication adherence. Reassurance to alleviate stigma. Advise on monitoring for new lesions or symptoms. Follow-up plan, monthly visits to assess compliance and response. Monitor for potential drug side effects. Outcome: at 6 months, lesion showed repigmentation. Sensation improved. No new lesions developed. Post-treatment surveillance, annual checkups to monitor for recurrence or progression. Discussion, key learning points, early diagnosis in children, critical to prevent progression and disability. Indeterminate leprosy, represents the earliest stage, may progress if untreated. Management, PBMDT is effective, doses adjusted for pediatric patients. Public health aspect, screening of contacts and community education are important. Conclusion: leprosy remains a complex disease requiring a comprehensive approach to diagnosis and management. As dermatologists and residents, your role is pivotal in early detection, appropriate treatment, and prevention of disabilities associated with this disease. By staying informed about current protocols and maintaining a compassionate approach, you can significantly impact the lives of those affected by leprosy. Thank you for your attention and dedication to advancing your dermatological knowledge. If you found this lecture valuable, Please like the video and subscribe to our channel for more insightful content. Your support helps us continue sharing essential medical information. Let's keep learning and making a positive difference in our patients' lives together.